from your A and P that they are two pyramidal type shaped glands that are on top of each kidney. You have two sections, one is a medulla and one is a cortex. And 90% is the outer layer and 10% is the inner layer of it. And you have that on your notes there. And this is just another little caricature showing you that. So the functions of the medulla, it does secrete two catecholamines. Those are epinephrine and norepinephrine. And the primary source in your body, it represents about 80% of your epinephrine comes from that, and 20% comes from your sympathetic nervous system. Underactivity or loss of medulla causes you very little problems because your sympathetic nervous system compensates and takes over. So you really wouldn't even know that you were lacking in those. And overaction or overactivity of it causes severe sympathetic nervous stimulation. And we're going to talk about that in a little bit at the very end of the notes, what happens when you have too much epinephrine and norepinephrine produced. So the first grouping that we're going to talk about are problems with the cortex. There are three groups there. They are the only source of glucocorticoids and mineralocorticoids within your body. So if we would remove your adrenals, you would have to have a lifelong replacement of these types of hormones. It secretes about 30 different types of steroidal hormones, but we have some main ones that we're going to talk about. The first one are mineralocorticoids. Those are responsible for regulating sodium and electrolyte balance. Aldosterone is that primary mineralocorticoid that we're going to be discussing. It's responsible for maintaining extracellular fluid volume. It causes the renal tubules to reabsorb water, sodium, chloride, and it decreases the reabsorption of potassium. So when you go to study, you're going to kind of need to know what these hormones do and what they regulate, because you'll see a correlation then between the disease process and these electrolytes. So once you learn one, the other one is just the opposite when we have hyper or hyposecretion. The second grouping or type of steroid that's important are the glucocorticoids. This primarily is cortisol. It's the number one hormone. We also have cortisone and corticosterone. They do increase blood glucose levels. They increase protein catabolism and conversion to glucose, They're responsible for sodium retention. And they have some anti-inflammatory effects. So these are going to be released or increased production if you have some type of inflammatory process. You get some type of infection, some type of wound, something like that. It helps decrease your reaction to injury. Number 5, large amounts are released with a lot of physical or mental stress. It helps the body cope. So I'm sure in the past couple of years, you have very much stressed out your adrenals with getting through a nursing program. And remember, the peak release for steroids is in the morning. And then they taper off as the day progresses. So this past probably almost month, 2 months, and I don't know about Mansfield, but we have given lots of Solu-Medrol, right? Because we've been taking care of lots of COVID patients. That Solu-Medrol is a glucocorticoid, and yet we give it sometimes every 6 hours. So these people not only have been taking it in the morning, the afternoon, the early evening, and at bedtime, and then sometimes your patients will complain that they can't sleep. Your normal body response should have been that we produce the most in the morning, and by 3 or 4 o'clock, that production is pretty much tapered off to nothing. And then that allows you to settle down, relax, and actually sleep through the night. So those people that are getting steroids continuously, in a 24-hour period often will reflect problems of sleeping, being able to calm down, relax when they're taking those. So that's just something to keep in mind. Your normal body production should shut down towards late afternoon. Now, if you're a 30-year night shift worker, that production has flip-flopped. Okay, your least production would be in the morning, and your most production would be towards evening when you were ramping up to go to work. So it can actually, the cycle of it change depending upon what your body habits are. All right, so we had mineralocorticoids, glucocorticoids, and we're going to have the sex hormones. These aren't quite as important because you don't necessarily have to have them to sustain life, but they are important as we talk down some of the characteristics or things that can happen. You might want to replace those. And then our third thing, how you can remember the hormones, are that you need salt, sugar, and sex. Okay, so not too bad. You got to have McDonald's French fries with lots of salt. You got to have a good old candy bar, and you got to have a little sex in your life. I take those three things. They're pretty good. All right. So that's an easy way to remember what those hormones do. Okay. When you go to study for them. All right. So let's talk about the adrenal cortex and hypofunction. The primary disease process here is adrenocortical deficiency. We call it Addison's disease. 1 in 100,000. Usually folks that are a little younger than 60 were diagnosed, and females have a greater tendency than males. Well, what causes a hypofunction of our adrenals? What causes them not to want to work very well? Well, we can have an autoimmune disease, which is most likely the cause. In about 80%, we have some type of autoimmune disease. It kind of attacks the gland and really kind of atrophies it, so it's not functioning very well. So when we do autoimmune disease, we really don't know why the body does attack itself, but it just happens. The second type is that the gland itself could be destroyed from some type of tumor. Maybe we've had a surgical removal of them, or we've had a kidney removal, something like that. Chemotherapies can attack the adrenals. If we've had tuberculosis, histoplasmosis can affect the adrenals and cause damage to them. So there's some variety of things that could cause that. Some other possible causes might be some type of trauma, anticoagulant therapy, where that actually causes the adrenals to hemorrhage. And a big one is open heart surgery. They have found that post-operatively, sometimes long-term in our open heart surgery patients, they actually have had some type of like infarct to the adrenals. And then the medications that we keep them on post-open heart actually causes damage to the adrenals. So those people long-term may have to have some type of replacement. But just if you highlight, the primary reason is an autoimmune. 80% of our patients, it's an autoimmune piece. Okay. Secondary adrenal corticodeficiency is going to be from a lack of stimulation to the adrenals. So if you go back and think of your A and P, remember we had the hypothalamus, the pituitary, and then the pituitary secreted all of these stimulating hormones, and then they went to their target organ. So we had thyroid hormone. It went to thyroid stimulating hormone, went to the thyroid, and it stimulates T3, T4. We have ACTH that goes to the adrenals, and that's what stimulates the adrenals to produce or function. So it's kind of a feedback system. So we always look at the target organ first. So if we had an issue with mineralocorticoids, glucocorticoids. We would go and look at the adrenals first. Oh, they pan out, everything looks good there. Now we're going to go back up and we're going to look at the pituitary. And so we call that a secondary problem, okay? Because if we could get the stimulation to the adrenals would work just fine. In this case, we can't get the stimulation, so the adrenals don't know to produce or release those steroids, okay? So what do we look like when we have problems with these? Well, the clinical manifestation is related to a decrease of those vital hormones, so we're not producing enough. And when we have decreased aldosterone, remember it normally conserves sodium and excretes potassium. So we're going to have an increased water excretion. And then now at senior level, when we say you're depleted in fluids, you should be able to pick out some of these things. We're going to show symptoms of dehydration. So we might have tenting of the skin, our hypotension, so our blood pressure is going to decrease. Our cardiac output's going to decrease. If you continue to have this issue, we can actually have severe hypotension, severe cardiac output is decreased, and we can actually have death from not having these hormones. So these steroidal hormones are very important for life. They last in the body for a while, but eventually they do become all depleted, and we can actually die from this. Our second thing, we said it's a potassium issue, so we're going to have potassium retention. Our body does not like to store excessive amounts of potassium, so that elevated potassium up around 7 milliequivalents per liter can cause cardiac arrhythmias and can cause cardiac standstill for us. Some things before we get to those major problems, remember some of our GI symptoms: cramping, diarrhea, weight loss. Those are all symptoms of excessive potassium. And then our third thing would show a lower sodium level. Okay, so that's a decreased aldosterone. Well, what happens then when we have a decreased glucocorticoids? Well, we have decreased gluconeogenesis, and that's a term, a flashback, a nightmare flashback from anatomy and physiology, I'm sure, making glucose from proteins. B, we're going to have a decreased overall blood sugar. The patient will complain of being weak. It should be a Z in there. Anorexia, nausea, vomiting, weight loss. Glucocorticoids also help us with a mood, so they can be mild to deeply depressed. And our ability to handle stress, or even minor stress, can be affected. Some other signs and symptoms then, if we looked at our labs, it would show a low sodium, fasting blood sugar, high potassium, and that should correlate with the information I just gave you. A lack of corticosteroid stimulates the pituitary. So in blood levels, you might see an increased ACTH. These folks with Addison disease, one of their characteristics that almost all of them have are an increased melanocyte, and so their skin actually takes on a bronzed or smoky appearance. It's mostly seen in their face, their neck, their hands, any creases. So I kind of relate it to tanning creams. Most men don't use tanning creams, but ladies, you may have growing up. They've very much improved. But when I was in my teens, we had like copper tone tanning. And if you didn't wash your hands, the creases would all be extensively brown. It would have a real funky, odd color. So think of your bronzers or your tanners accumulating in creases or places where there would be ripples. So Not necessarily would you put it in your buccal membranes, but nipples, genitalia, those kind of things all have bumps and lumps, and that's kind of where that melanocyte accumulates. 98% of your patients with Addison's will have this increased pigmentation. So it's a very classic symptom of Addison's disease. And this is just a little caricature, a picture of the things that can happen. We said it was an autoimmune. This one talks about an iron overload, Addison's, hypotension, hyperkalemia, sudden death. So you can look at that as you're studying and try to equate that to our previous information. So how do we diagnose adrenal insufficiency? Well, pretty much we're going to look at their lab work. So we said they would have that very high potassium. We would show a decreased fasting blood sugar. We would have a decreased sodium and a decreased chloride. Then the other thing we can do is a 24-hour urine. These are specifically looking at steroidal.
Is it just me? I'm sorry.
Go ahead, Summer.
You're cutting out. I don't know if it's just on my end.
Amber, any issues?
No, I can hear you fine.
Okay.
There's some moments where it's almost like it pauses. So yeah, that's all I'm hearing.
Okay. All right. Well, I'm out at school, so who knows with their Wi-Fi system. So I apologize. When I open up the PowerPoint in your Canvas, there actually is a voice over PowerPoint with me telling you this, lecturing the same thing. So if need be, you could listen to it again. Okay? So if it's breaking up, that will be there for you. Okay? They have little, you can see the little sound symbol on the bottom. You can click on those and it actually will play me lecturing on the slide. So hopefully for those of you, if it's cutting out, you'll be able to utilize that. But the main thing here is you're using a 24-hour urine collection. Those are specific to what you're collecting. So lab will let you know if there's some type of dietary restriction, something that you need to put it on ice. Lab will let you know, okay, what your priority things are when you collect certain 24-hour urines. And this would be a specific one, okay? So they will let you know if there's something you need to take out of the diet or you need to handle the urine a specific way. Okay, so how do we manage then chronic Addison's disease? Well, we're going to give them glucocorticoids, so some type of cortisol or Cortef. 2/3 we said again would be in the morning, 1/3 would be given by late afternoon. We talked about if they don't do that, they can have insomnia from it. And a lot of times our patients can actually be switched to just taking their steroids every other day if they're able to maintain their levels. So what do we teach the patient then? Well, we teach them to watch for side effects. They're not able to adapt as well as somebody who has a truly functioning gland. So their lifelong replacement, they need to take them exactly as their physician prescribes. Again, this would be one of those patients that I would probably be under the care of an endocrinologist versus just my family doctor. You probably need to be seeing the specialist to have this. Notify the doctor if you go having any undue stress infections. Even minor ones can throw things off. Surgeries. If you're somebody who works for like Kokosing and you're doing asphalt paving and stuff in the summer, or you're putting on roofs, or you're anywhere where you have excessive diaphoresis, you would need to let the physician know or work on doing some type of adjustment in those time periods. Sometimes your doses will need to be increased by 2 to 3 times during stress. We teach the patient to take them with food so they don't have stomach upset. If you are physically sick, you would need to take them by intramuscular injection. We don't just skip them. We never run out of our steroids. We wear a bracelet that says they're adrenal insufficient, and you want to keep an emergency kit with you. Okay, so that, I mean, when I say it is necessary for life, it is necessary for life. If they don't have these things, we're going to talk about Addisonian crisis here in a few minutes, and it is life-threatening that they can go into if they do not have their medications. All right. Third thing, replacement of aldosterone, our mineral corticoids. So our glucocorticoids are our most important to us. Replacement of aldosterone oftentimes is in the form or the medication of Florinef. They can take it every day. Sometimes it'll go to 3 times a week. Really what we're trying to do here is keep our sodium and potassium balance. And again, depending upon the weather, it may need to be adjusted. Dietary teaching, this is going to be real important. The sodium needs that they have can oftentimes just be met via their food consumption. But however, if they're sick or unable to eat, they may end up in the hospital just to have sodium replacement for that. If it's not some type of GI system upset, but some other physical ailment, they may need to increase the amount of sodium they consume by taking salt tablets. We've had patients in the hospital that have been on salt tablets where they've had to take increased amounts of sodium. They also get a high protein diet. We want a high complex carbohydrate diet, and we want to avoid a lot of concentrated sugars. Remember, they do have problems regulating their blood glucose. So we want to make sure that we have complex carbs and not just Snicker bars and those kind of things where we just have concentrated sugars. It's going to be a little harder for them to maintain their blood glucose level like that. Then the number 5, this takes into consideration our sex hormones, the androgens and stuff that may not be properly produced. So if they have some type of muscle wasting, something like that, or seem to be malnourished, we can add testosterone to their system, and that would help with muscle building, etc. And it has a anabolic effect for them, so it would also be helpful. But again, being under the care of an endocrinologist would be extremely helpful to manage all 3 of these replacements. So what happens when we don't have a sufficient amount of adrenal production, or we don't take enough glucocorticoids? Well, our patient can go into what we call an Addisonian crisis. It's the critical need of the body for glucocorticoids. It occurs when you have a sudden increase in stress in the patient, with somebody who has chronic Addison's disease, or with anybody who's been on long-term glucocorticoid therapy. So if Taylor is my patient and she has juvenile arthritis and she has been taking steroids all her life, Taylor could just not stop taking those right now and be okay. Her adrenals have shut down because she's getting an artificial glucocorticoid. Her adrenals have not had to make their own for a long time. Therein lies the crux when we tell you when you take steroids, why they do a tapering effect. Okay? Have you ever taken steroids for a bad case of poison ivy? And you start out with a high dose, and then they taper you off. We don't start out with a high dose and take it for 5 days and then cold turkey, we stop. because while you're taking those high doses of steroids, your adrenals do not need to function. We need to start them back up functioning, and we start them back up functioning slowly. So no matter why you take steroids, you cannot stop them cold turkey. Okay, and if you've been on a lifelong replacement for them, you definitely cannot stop that, or you will go into an Addisonian crisis. So you can kind of highlight that patients who fail to take their steroids when they've been taking them, that would be a no-no for them. Complications of surgery, when 90% of your adrenals have been removed, could cause an Addisonian crisis. We can have shock type symptoms from that. We can have infection, severe infections could cause it. They can have dehydration. So these folks can be very sick. Their manifestations, when we talk about symptoms, severe hypotension, so you would watch their blood pressure. They can have a high fever, headache. They have very high potassium levels, again, low sodium levels, dehydration. Low sodium levels can cause confusion for folks. They can have low blood sugars. They can have dysrhythmias. And then the bottom line is they can have cardiovascular collapse and then death. So it is something that we have to monitor for. And when we do have patients that have that, the treatment is going to be fluid volume, sodium, and steroids. Okay, so restore their fluid volume, their sodium. You can see their glucose, so something like a D5.9 that gets you sugar and salt. Okay. We need to replace their glucocorticoids, so we can give them Cyacortef, Cyamedrol. We know we can give those IV push. So we wouldn't mess around with oral supplements here. We would do IV. We said that they could be somewhat shocky. So we could do plasma expanders, oxygen therapy, vasopressors, things to push their blood pressure up. We could treat if it wasn't from lack of taking the medications, but an increased stress because they had some type of sepsis or infection. We would want to help take care of those issues. So we would do antibiotic therapies to help resolve the problem. For Addisonian crisis, we treat it just like shock. We decrease stimulation, so we keep them very quiet, keep them on bed rest. We don't let them exert a lot of energy. And then the patient response usually is within hours. So as long as you can replace their fluids, their salt, their sugar, and their steroids, they will respond very quickly for you. If you do not do that, number 4 will occur. They have cardiovascular, renal collapse, and death will occur. Okay, so it definitely, you have to have it to live. You have to have your glucocorticoids or, like I say, it circulates in the body for a while, but once those levels are depleted, these are the symptoms that your patient is going to have. All right, our next one then is adrenal cortex hyperfunction, and we call this Cushing's syndrome. It's a little rare, only about 10 per million. Males and females equally, around that 30 to 50 year mark. Usually it is from some type of primary tumor that secretes too much steroids. Secondary can be from excessive ACTH stimulation from the pituitary. And when the pituitary is the cause, we call it Cushing's disease. And I'm not going to ask you between syndrome and disease, but you will see those terms thrown out there separately. So Cushing's is when the pituitary is involved, and Cushing's syndrome is when the adrenal is directly involved in the problem. Again, we can have a pituitary tumor, and when we talk about the pituitary here in another week or so, you can have a benign tumor that secretes excessive ACTH, and that can cause the problem. One of the other problems could be prolonged cortisone therapy also. And what it does is then it shuts down the adrenals. We just previously discussed that too. Then when we get to lungs, there is an ectopic lung tumor that produces ACTH from the tumor, and we call those small cell lung CAs or bronchiogenic lung cancers. And we'll hit that again when we get to the lung piece, but sometimes the patient is being treated for an adrenal issue, and it's really not the adrenals causing the problem, but this small cell lung cancer. So our treatment for our lung cancer gets delayed because we believe it is a adrenal or an endocrine issue and not really a lung cancer issue. So we'll hit that again when we get to the chest, but that can delay our diagnosis of our lung cancer because they're producing these ectopic hormones. So what are some clinical manifestations then of our Cushing's syndrome? Well, the cause can be persistent hyperglycemia, and this is due to an increased gluconeogenesis and a decreased ability to utilize insulin. So in the end, the symptom here is an elevated fasting blood sugar. On these folks, you'll also see a protein tissue wasting. So they have very thin arms and legs. They can have pathological fractures or osteoporosis, causing compression fractures. They can have capillary fragility, which means that they would have slow bruising, I'm reading both of them at the same time, easily bruised, and they would have a slow wound healing. They have potassium depletion, so it can cause weakness and arrhythmias. So weakness and arrhythmias, there's a spelling error, Lisa. They can have sodium and water retention, so they can have edema throughout their body. They get kind of a typical moon face. So I think you can pick those people out that have been on long-term steroidal therapies. They get kind of a moon face. They have an abnormal fat distribution, so they have a buffalo hump, and that's at the back of the neck. They have a fat deposit. They have truncal obesity, so they have a very thick trunk, but they have the skinny little arms and legs. They also can have striae on their abdomen and breasts. Remember, that's a tear in that connective tissue. They also can have immune suppression, so they have an increased risk of infections. And they can have mental changes. Their mood swings can go clear to the extreme of psychosis. So they have a lot of physical things that you can see with our Cushing's. Not quite as much on our Addisons, except the skin pigmentation is very obvious for them. Okay, so we'll go to some diagnostics then. So again, this is just a little caricature kind of pointing out what's going on. Remember, there are some things that go on because of the excessive amount of androgens that are produced too. So there's the amenorrhea. There are some things related to those sex hormones that can alter things also. Diagnostics, again, a 24-hour urine is going to show that elevated cortisol, potassium, calcium, glucose. Their blood level of cortisol will be elevated. They have an increased blood glucose. It'll show a low potassium, low calcium, increased WBC. Now remember, a lot of these are opposite. Your 24-hour urine is the opposite of what you have in the blood because it's excreting excess amounts. So even though your blood work shows a low potassium, a low calcium, your urine is going to show an increased amount because it's excreting that. And then the CT and the MRI, those are necessary to check for tumors. And then the increased WBC there, we said, you know, these steroids help you deal with stress, infection, those kind of things. So if that's not there, then that inflammatory response doesn't get in check, it's out of check. So you'll have an increased WBC. So there's kind of a caricature again of our folks with Cushing's syndrome. You can see he has skinny little legs, skinny little arms. He has more truncal tissue than he does anyplace else. He has a cast on his leg, so he's at risk for fractures from his osteoporosis. He has a lot of bruising. There on, you can see females, males from the increased androgens that are there. The moon face for excessive amounts of steroidal production. Doesn't show the buffalo hump, but that's a pretty classic one. Treatment, without treatment, about half of our patients with adrenal excess will die. For adrenal tumors, they can do unilateral or bilateral adrenalectomy. If they do take both out, remember you'll have to have a lifelong replacements. We don't want to have Addison's disease, so if we take the adrenals out, they have to have replacement. If it's metastatic, chemo with the adrenal suppressing agents. So if it would be some type of cancerous tumor that would be causing it. For a pituitary hypersecretion of ACTH, meaning it's not an adrenal issue at all, it is a pituitary issue, they can have irradiation of the pituitary. We'll talk about it. I don't know when that comes, next week or not, but they can also freeze it. They can do a cryosurgery, or they can do a hypophysectomy. And that's just a surgical removal of your pituitary. And those medications, I don't know if your new book, let me see. Look real quick for you here. if it talks about medications. It does talk about medications. So not necessarily page 1439, but page 582 in your new book does talk about medications with Cushing's. So 582 talks about those a little bit. Nursing care and teaching related to Cushing's. A low calorie diet. Remember, they have a lot of truncal obesity, low sodium. These folks need high potassium, vitamin D, calcium. Remember, they have osteoporosis, so we need to counteract that a little bit. We watch them for edema. We watch vital signs for an elevated blood pressure. We monitor them for diabetes. They may even need to take insulin along with oral medications for that. We encourage short walks. They are a risk for injury, so we don't want to do things that would cause them harm, compression fractures, those kind of things. So, you know, if there's somebody that belongs to the Y and can get in the pool and swim a little bit, that would decrease wear and tear on their joints. Protect from falling, again, due to fracture. A calm environment. Remember, we said they could have mood swings, clear up to psychosis, so they don't handle stress very well. Emotional support, and then monitor for them for adrenocortical insufficiency, because as we give medications and treatments to decrease their adrenal production, you could throw them into an insufficiency. Again, one of those highlights for seeing the endocrinologist, so they can kind of keep an eye on where those blood levels are at and monitoring you to make sure that you don't go into some type of adrenal cortical insufficiency for having treatment for Cushing's. All right, I think all those are listed for you there. So the last piece, this is a pretty short lecture guide because there's not a lot with this one because the adrenals are pretty small and only have a couple things that go wrong with them. But the other piece of the adrenal is the medulla. So we were talking about the cortex with hyper and hypofunction. For the adrenal medulla, we really only talk about a hyperfunction, and we call it a pheochromocytoma. The cause of those is usually some type of benign encapsulated tumor in the adrenal medulla. And it secretes excessive amounts of epinephrine and norepinephrine. The clinical manifestations for these folks is that you might see a blood pressure of 300 over 200 or higher. Those blood pressure episodes, or these episodes that they have, usually last no longer than about 40 minutes, but over time they do start to last longer. So if you had a blood pressure of 300 over 200 or higher, I'm sure you would be having some type of heart palpitation. Your vision would be affected. You're probably sweating, and you have the other signs and symptoms of an increased amount of epinephrine being produced. So when you think about how much epinephrine and norepinephrine is being produced, the complications would very much go hand in hand. Stroke, blindness, cardiac failure, sudden death. So these patients will come in because they feel awful to the emergency room, but they're not sustaining. So the blood pressure might go up and then it would go down. But as the weeks and months progress, it's a paroxysmal type signs and symptoms. They progressively last longer and are happening more frequently. So they're pretty much diagnosed a lot of times by a 24-hour urine. And what we're watching for here is an excessive amount of VMA or catecholamines within the urine. And these are the end products of epinephrine and norepinephrine and catecholamines. So this would be excessively high in people that have pheochromocytomas. So it's a 24-hour urine collection. You can see that they do have to restrict diet 2 to 3 days prior to and during their urine collection. I'm not testing you on those VMA restrictions. Just know that when they are taking or doing this 24-hour urine, there are things that they are going to have to limit in their diet while the collection is taking place and 2 to 3 days prior to. And there may be some medications that they also have to restrict. Their hypertensive meds, those kind of things, because it can affect production. So they would need to, again, check with a physician. They're going to tell them what they should take and what they shouldn't take when they're doing this 24-hour urine collection. So we've done a 24-hour urine collection. We have diagnosed you with a pheochromocytoma. What is our treatment for this? Well, we're going to surgically remove your tumor. 90% are curable. Most of them are benign tumors. Only 5% are malignant. So you have a very good cure rate. Preoperatively, we're going to give medications to try to control your palpitations, your heart rate, your blood pressure. So adrenergic blocking medications, Inderal. Postoperatively, in the first 48 hours, these are probably going to be patients that might even end up in your ICU to be monitored because their blood pressure fluctuations will continue. Just because you remove that tumor does not mean that you automatically reduce your epinephrine and norepinephrine blood levels. It's going to take maybe up to 48 hours for those levels to start decreasing. So we're going to see highs and lows in their blood pressure. Because we're still seeing highs and lows in their blood pressure, remember we just did surgery. So if it was a pituitary tumor, we did a cranial surgery. If it was kidney, we did a abdominal surgery. They are at risk for hemorrhagic issues. They're at risk still for arrhythmias. And then they need to take corticosteroids to replace the loss from the removal of the adrenals. Sympathetic nervous system will take over for the adrenal medulla. So we really do not need to give them supplemental norepinephrine, epinephrine. Your own body's response system will be enough for that. There are really no ill effects from not producing that. But because we have taken the adrenals out or we have taken the pituitary out and we don't have ACTH, you do have to replace the corticosteroids. So in other words, now we really will be watching them for Addison's if they don't take the proper medication. "24-hour urines, if you've not done one of those in a long time, you have to get a special container from lab. Follow the instructional guidelines to the T. Whatever they tell you the patient needs to do or the home patient, they need to do it. You void at the beginning. So the first void is always dumped. And then you collect from that point on for 24 hours. So you'll see signs at the back of the toilet. You'll see signs over the toilet, because the mistake that we happen to have is that we empty the urinal or the bedpan or something and the urine goes down the toilet and we need it in the collection container. Any lost specimens oftentimes will void the test. And most 24-hour urines need to either be kept in a refrigerator or on ice while they're being collected. So your home care patients may put it in the refrigerator. Your patients, obviously, at the hospital or at the nursing home, you'll probably put in a cooler with ice. So I just wanted to go back and circle around and make sure you knew how to do a 24-hour urine collection. All right, so for your test, you will have to know the difference between your deficient patient, your Addison's, and your person who's producing too much, your Cushing syndrome patient. The labs pretty much are the opposite. So, if you struggle with learning material, this is one of those where you kind of have to go back and kind of memorize at least one of them. And then you can kind of figure out Cushing's is just the opposite. Or if you've got a good handle on Cushing's, Addison's is just the opposite. And then do make sure that you understand what these do. Like your mineralocorticoids is for sodium and fluid production or retention and excretion. And your glucocorticoids, what are they responsible for? I think it'll help you with symptoms when you look into the Addison's and Cushing's. And then you also will have to know your Addisonian crisis and what happens there. Okay, what those patients look like. And then if you can just remember what happens when you have too much norepinephrine or epinephrine, I think you've got the pheochromocytoma down. That would be kind of being in flight mode all the time, right? Like somebody startled you and you get a release of epinephrine and norepinephrine, that sympathetic nervous system stimulation. It'd be like being in that modality for 40 minutes and then it cuts off, and then maybe 3 days later it kicks on again for no reason. And then they progressively get longer. Okay, I'm going to stop sharing my screen. I'm going to give you a little bit of a break here. Come back at about 5 after, and let me see if I can get onto Canvas and open up your other pieces and parts.